Good morning, everybody. This is workshop 10, the Airway Physiology-directed Therapies workshop, so thank you for coming. I'm Jonathan Raymond from Vancouver, and we have Carla Ribeiro with us today as my co-chair, who's filling in for Ray Pickles. So thank you, Carla, for filling in at the last minute. I'm really excited about this session today. So the title of the workshop is Airway Physiology-directed Therapies, which in CF can encompass a lot of things. And I think the lineup of distinguished speakers that we've selected today reflects that can encompass a lot of things. So we've got a wide range of therapeutics, study models ranging from cell biology to clinical studies. And it really is across a wide spectrum. So I'm quite excited about our lineup of speakers today and really looking forward to it. A couple of housekeeping things, just to remind everyone, please to put your cell phones on silent. And to tell you that there is, so I have this iPad thing here that is live for a Q&A session through the app. Preferentially, if you're in the room, it would be better to come up to the microphone because these workshop sessions really function the best when there's lively discussion. The talks are 15 minutes with 8 minutes for questions. So there's lots of time for questions. So if we could have as many people coming up to the microphones as possible to keep the discussion going, that'd be great. For people who are online, we will be checking the app for questions there. So you can do that as well. And I think that is it for housekeeping, so we can just dive right in. So our first speaker today is Dr. James Tull from Vanderbilt, who's going to be talking about the pharmacodynamic effects of brensocatib in patients with CF. So Dr. Tull, please take it away.
Yes. All right. Okay. All right. Well, good morning. I'd like to thank the session chairs for inviting me to speak today. My name is James Tull. I'm the Adult Cystic Fibrosis Program Director at Vanderbilt, and I was one of the site principal investigators for this multi-center trial. And I'm going to be talking today about the pharmacodynamic effects of brensocatib in patients with cystic fibrosis. There are no relationships to disclose related to this presentation. So by way of background, neutrophil serine proteases, including neutrophil elastase, cathepsin G, and proteinase 3, are activated by dipeptidyl peptidase 1 in the bone marrow. Brensocatib is an investigational DPP1 inhibitor. In the phase 2 WILLOW study that was published in the New England Journal in 2020, brensocatib prolonged time to first exacerbation in patients with non-cystic fibrosis bronchiectasis. Patients with cystic fibrosis share many pathophysiologic features with patients who have non-cystic fibrosis bronchiectasis. However, CF patients have unique pharmacokinetic and pharmacodynamic alterations as a function of their disease state. The pharmacokinetic evaluation of brensocatib in patients with cystic fibrosis has been previously reported earlier this year at the European Respiratory Society Congress in Milan. And this data showed rapid absorption, dose-dependent exposure, moderate elimination rate, moderate exposure accumulation at steady state, similar to what had been seen in healthy subjects and in patients with non-cystic fibrosis bronchiectasis. The current study was designed to assess the pharmacokinetics, pharmacodynamics, and safety of brensocatib in patients with cystic fibrosis. As I just mentioned, the pharmacokinetic assessment has already been discussed previously. So here we will present the exploratory pharmacodynamic endpoints related to neutrophil serine protease data, including neutrophil elastase, cathepsin G, and proteinase 3. The major inclusion criteria for this study were an age greater than or equal to 18 years, a body mass index greater than or equal to 18 kilograms per meter squared, and a confirmed diagnosis of cystic fibrosis-related lung disease. The percent predicted FEV1 needed to be between 40 and 90% of predicted at the screening visit and at baseline. And stable CF treatment had to be present for at least 30 days prior to screening. Major exclusion criteria were severe or unstable cystic fibrosis in the investigator's judgment, current treatment for allergic bronchopulmonary aspergillosis, non-tuberculous mycobacteria, or tuberculosis, or unstable disease related to colonization with Burkholderia syncytiaceae, Burkholderia dolosa, or Mycobacterium abscessus in the judgment of the investigator. So here we see the study design. After a 4-week screening period, 29 subjects were randomized into 3 different brensocatib treatment arms and placebo. The treatment arms were brensocatib 10 milligrams per day, 25 milligrams per day, and 40 milligrams per day. Patients taking CFTR modulators, of which there were 21 of the 29, were stratified to receive active treatment in a ratio of 5-to-1 to placebo. And for subjects who were not taking modulators, of which there were 8, 7 received treatment and 1 placebo. The treatment period was 4 weeks, followed by an additional follow-up period that extended out to 8 weeks. Pharmacodynamic biomarker samples in blood and sputum were collected at screening and pre-dose on day 1, which is baseline, and then days 2, 14, 28, 29, and 35. This analysis presents data from change from baseline to day 29. 35 subjects were screened and 29 were randomized. 8 were randomized into the 3 different brensocatib treatment arms, again, 10 milligrams, 25 milligrams, and 40 milligrams per day, and 5 subjects were randomized to placebo. As mentioned, there was stratification of modulator use across each group. So 6 of the 8 subjects in the 10 and 40 milligram per day arms were on modulators, and 5 of 8 in the 25 milligram per day arm were on modulators. 4 of 5 subjects in the placebo arm were on modulators. No subjects discontinued study treatment, and no subjects were discontinued from the study. Here we see the demographics and baseline characteristics. Column 1, all participants, 29 subjects. The mean age was about 38. There was a preponderance of males with 62%. The majority were over 30 years of age. Body mass index was normal, and percent predicted FEV1 was about 65% of predicted in this group. You can see here the breaking out of the patients taking CFTR modulators and those not taking CFTR modulators. Of the 21 subjects taking modulators, 19 were taking ETI, 1 was taking tezacaftor, ivacaftor, and 1 was on ivacaftor alone. And in comparing these 2 groups, there's similar age and similar gender distribution. The body mass index is slightly higher in the patients not taking modulators, and there was less pancreatic enzyme use. The percent predicted FEV1 was lower in the CFTR modulator group, 61.6 versus 73.1% of predicted, suggesting perhaps some overall increased severity of disease in the patients taking CFTR modulators at baseline. So moving into the pharmacodynamic endpoint results. So here we see the median percent inhibition of neutrophil elastase activity relative to baseline on day 29. And what is demonstrated is a consistent trend of treatment effect, particularly in the brensocatib 25 and 40 milligram per day dosing arms. In the blood, there was a median reduction of approximately 56% and 74% respectively, and the sputum 78% and 70% median reduction respectively. For cathepsin G, there was a similar consistent trend of treatment effect, particularly in the 25 and 40 milligram per day dosing arms, evidenced in blood with median reduction of approximately 92% and 96% respectively. As you can see, the data in sputum is quite limited due to a very small sample size and significant variability in those results. For proteinase 3, the median percent inhibition of proteinase 3 activity relative to baseline at day 29 also demonstrated a treatment effect that appeared to be dose-dependent in the blood data with a significant increase across each of those arms. In the 25 and 40 milligram per day dosing arms, a median reduction of about 41% and 55% respectively. There was a significant reduction in sputum, although no dose-dependent relationship observed. Of note, that 40 milligram brensocatib arm really was one subject, which limits the analysis there. So this table shows the data of median percent inhibition of neutrophil elastase activity in the blood in patients with cystic fibrosis from this study, also looking at the reduction in patients with non-cystic fibrosis bronchiectasis from the WILLOW study published in 2020, and in healthy subjects from brensocatib phase 1 data. And these are not meant to be compared side by side statistically. These were all taken from different studies with different sample sizes and obtained in different fashions. But just to demonstrate a consistent trend across the brensocatib treatment arms in all three groups with significant inhibition of neutrophil elastase activity in the blood. There was no 40 milligram per day dosing arm in the WILLOW study for non-cystic fibrosis bronchiectasis patients. So there are limitations. The interpretation of these exploratory neutrophil serum protease data are limited by a small data set, high variability at baseline for blood and sputum activity, the quantity of samples, particularly in the sputum, and the assay variability due to the complexity of the sample. And of course, comparisons among these other studies in different populations are limited due to the number of participants and the conditions in which these samples were obtained. In terms of safety data, the reported treatment emergent adverse events were similar across all four groups. Most of these adverse events were mild to moderate in intensity. There was one severe adverse event reported in the 40 milligram per day dosing arm, which was a CF exacerbation that required hospitalization. There were two adverse events related to COVID-19. The most common adverse events are listed here below: CF exacerbations, headaches, abdominal pain, cough, increased sputum. There were no new safety signals. There was no discontinuation due to adverse events. There were no adverse events of special interest, which are hyperkeratosis, periodontal disease, pneumonia, or serious infection, which comes from data in the congenital absence of DPP1. And there were no deaths reported. And overall, this safety profile was comparable to that seen in the WILLOW study with patients who have non-cystic fibrosis bronchiectasis. So in conclusion, brensocatib demonstrated a dose and exposure-dependent inhibition trend in both blood and sputum neutrophil serine proteases. These results in patients with cystic fibrosis are consistent with previous findings in patients with non-cystic fibrosis bronchiectasis and in healthy subjects. And brensocatib was generally well tolerated across the different doses with no new safety signals reported. I'd like to acknowledge that the study was funded by Insmed Incorporated. Medical writing was through Envision Pharma Group that was also funded by Insmed. All authors contributed to and approved this presentation. And of course, we want to thank patients, their families for their participation and support, study investigators, study coordinators, support staff across all of these sites. These are the 25 sites across the United States with the principal investigators listed. I'll move on to Q&A.
So we'll open it up to the floor for questions. And if you get to a microphone, please just start talking. We can't actually see because of these lights. I can kick it off. Was there any subgroup analysis looking at the responsiveness in people on modulators versus not on modulators?
No, from this data analysis, there was not.
Okay.
There's just a similar distribution across the groups.
Okay. Because I think that's, I think that's the fairly obvious question with an anti-inflammatory right now is how much value does it add in the context of people who are on Trikafta?
Right.
Is there, what's the next plan to look at that?
Well, that data certainly, from the sponsor level, may be able to be analyzed. It's not been analyzed for our presentation today, but 19 of these 29 subjects were taking ETI, right. So at least the majority, vast majority.
Okay.
One question. Hi, James J.P. Clancy from CF Foundation. Were they looking at? Did they look at lung function? Was there any signal to be shared?
Yeah. So obviously the study was not really powered to look at these clinical endpoints over this short period. So there was, relayed to me is no difference in lung function CFQR scores for this sort of limited set of data.
David Hill from UNC, Yanni taller mic stands. But, yes, everyone take a look. I'm tall. Yeah. I was wondering if you had enough power to see if there were any differences in the gating mutations that the patients had, and when you were looking at sputum, if you did any other biomarkers in sputum like concentration or DNA concentrations to see if you're having an add-on effect there.
So I don't believe there's any breakdown of data by genotype. With regards to the latter and that data, I'd have to refer that to the sponsor, to INSMED. I'm not sure if that data was collected.
So along the lines of JP's question, I'm Ron Rubenstein from Washington University in St. Louis. What are people thinking about an outcome measure for a phase 3 trial?
Right, it's a great question. I mean, the huge question. Exacerbation, time to exacerbation rates would seem to be the thing based on the non-CF bronchiectasis data in Willow. There's, many of you probably know, there's a large phase 3 study of brensocatib in non-CF bronchiectasis ongoing right now. So I believe once that is available, sort of modeling off of that, but I suspect that's also, exacerbation rates and time to exacerbation. Which would be, I think different. We're used to FEV1 and that being one of the major endpoints, but I think based on its anti-inflammatory properties, probably exacerbations and exacerbation rates and quality of life.
Does anyone, James or anyone in the audience, have thoughts on whether exacerbations can actually be used as an outcome measure anymore, given the current rate of exacerbations on ETI? I think that's the big question, right?
Well, it's a great question. Yes. I think obviously all of us being involved in clinical care, there still are exacerbations. It definitely decreased in number and severity, but it would make sense that you could still look at that. Whether or not it would be significant, of course, we don't know.
Oh, one more. Yeah. Alessandra Livraghi-Butrico from UNC. Not a clinician here, but is the increase in sputum production a common side effect of this treatment?
I mean, there were a few patients who had adverse events reported, and so it didn't seem to be a large signal, but there were a few adverse events reported.
Was it the same in the non-CF bronchiectasis?
I'm not sure about that in terms of AE. Good question.
Vanessa Diamond from Jonathan Raymond's lab, actually. So I'm just curious, given that we're sort of mentioning that maybe time to pulmonary exacerbation might not be the best, are there any sort of up-and-coming outcome measures, maybe from multiple breath washout or other imaging metrics that might be interesting for something like this?
Sure. I mean, it would make sense that other markers of sort of airway function in patients who have CF disease, and presumably some will have significant bronchiectasis, that those would be important endpoints. Multiple breath washout would make a lot of sense to see if there's some improvement in small airways function. So I think that would make natural sense. And I mean, obviously you'd like to see FEV1 as well, but whether or not one would see that, again, with the substantial improvements in stability of patients on modulators, I think it's pretty questionable. Imaging, I think, would be mostly limited by, I think it might be interesting to see investigationally whether or not it would be clinically feasible to do CT scans and that kinds of thing on patients. I think it's probably less likely, but it might be helpful to show some demonstration of effect.
Yeah, the Craig Lappin, Hartford. The problematic issue with that is with those indices is that it's going to be a lot more sensitive to evaluation in pediatrics as opposed to in people where the bronchiectasis may have already developed and the changes may have occurred. So is it one step too far, or is that going to be the next plan?
Thank you very much, Dr. Tull.
Thank you.
Well, continue this very exciting workshop. The next speaker is going to be Mohsen Tabassi, and the title of the talk is Low Levels of Nitric Oxide Generated from a Portable Nitric Oxide Generator Reduces Biofilm Bacterial Load and Improves Mucociliary Clearance.
Hello, everybody. Good morning. At the first, I would like to express my great appreciation to organizer to give me this opportunity to present my work. I am Mohsen Tabassi, postdoctoral fellowship at Lewis Katz School of Medicine, Temple University. And I will be talking about the use of novel prototype nitric oxide generating machine in reducing the biofilm bacterial load and improvement of mucociliary clearance. So, as you know, Pseudomonas aeruginosa is the most common bacteria isolated from cystic fibrosis patients. After colonization of Pseudomonas in the airways, elimination by antibiotic therapy is difficult because bacteria form and resides in the biofilm. Nitric oxide gas has been explored as an antibacterial and antibiofilm agent. Nitric oxide gas is a small hydrophilic and nonpolar molecule, allowing it to easily cross cell membrane. The antimicrobial properties of nitric oxide is due to the spontaneous reaction with oxygen and superoxide, producing intermediates responsible for oxidative and nitrosative stress. Two pilot clinical trials showed that inhaled nitric oxide therapy reduces bacterial load in CF patients. Extremely high cost and bulky equipment precludes a use of inhaled nitric oxide for home treatment. We have developed a novel portable prototype machine that generates gas phase nitric oxide from S-nitrosotiol, or SNO, by photochemical method. The aim of this study was to determine the effect of gas phase nitric oxide on the biofilm grown on mucociliary differentiated CF airway epithelial cells. This is a portable prototype machine which generates gas phase nitric oxide photochemically from RSNO cartridge. The NO level can be precisely regulated from 1 to 50 ppm with flow rates up to 4 liters per minute. The weight of this machine is about 2 pounds and the dimension 6 by 10 by 8 inches. In this slide, you can see a model for testing the effect of nitric oxide on biofilm bacteria. I have no access to pointer. Okay. We first culture CF airway basal cell at air liquid interface to generate mucociliary differentiated cell culture. The apical surface of the cultures were infected with mucoid Pseudomonas aeruginosa at 0.1 MOI or multiplicity of infection and incubated for 24 hours to promote biofilm formation. The culture were exposed to 10 ppm nitric oxide or room air for 8 hours. In some experiments, we added 0.1 microgram of tubromycin to the apical surface prior to the exposing to nitric oxide. Finally, 100 microliter of PBS was added and collected as apical wash to determine extracellular bacterial density. We also collected basolateral medium and used to determine LDH, IL-8, and IL-6 level. Cell were lysed in 0.1% treated X 100 for determination of cell-associated bacteria. This is the image obtained from immunofluorescence confocal microscopy and shows distribution of occludin and bacteria. Infected CF cultures show abundant mucoidal Pseudomonas aeruginosa macrocolonies on the apical surface of the cultures. These cultures also show reduction in intracellular localization of occludin, indicating barrier disruption. In this experiment, we used a mixture of 5 mucoidal Pseudomonas aeruginosa CF isolates to infect the cultures and then expose to room air tubromycin 10 ppm NO or 10 ppm NO tubromycin for 8 hours. We then determined the extracellular and cell-associated bacterial density. Our results showed that combination of NO and tubromycin reduced bacterial density by 4 to 5 logs and was significantly different compared to either NO or tubromycin alone. We also tested the effect of nitric oxide tubromycin on individual MP and found similar results. MP-infected CF cultures either exposed to room air or tubromycin show abundant mucoidal Pseudomonas aeruginosa macrocolonies on the apical surface of the cultures and reduction in intracellular localization of occludin, indicating barrier disruption. NO-treated cells show comparatively lower levels of bacteria on the surface, but still show dissociation of occludin from the intercellular junctions. Cell treated with NO and tubromycin show no bacteria on the cell surface and improves the localization of occludin to the junctions, indicating relatively intact barrier function. We also measured the effect of nitric oxide and tubromycin on MPA-induced pro-inflammatory cytokines. Despite reducing bacterial load, combination of NO and tubromycin had no effect on MPA-induced IL-8 release. MPA-induced IL-6 significantly reduced by nitric oxide, tubromycin, and combination of NO-tubromycin. We also measured the effect of NO-tubromycin on the ciliary bit frequency. CF cell cultures show impaired ciliary bit frequency due to the accumulation of dehydrated mucus on the apical surface. MPR further reduced the ciliary bit frequency. NO treatment improved ciliary bit frequency in both uninfected and MPA-infected cell cultures. We then wanted to examine the effect of nitric oxide on naturally occurring biofilm. We used CF sputum as a source of naturally occurring biofilm. We obtained sputum from 10 mucoidal Pseudomonas aeruginosa isolated from CF patient. Because of the limited quantities, we combined 2 sputum samples, resulting in 5 sputum samples. Sputum was homogenized with pipetting up and down, and aliquot of sputum was diluted on plate agar and Pseudomonas isolation agar for counting the number of bacteria. And finally, we measured that quantification of total bacteria and Pseudomonas in CF patient and found that majority of colonies on Pseudomonas isolation agar had mucoid phenotype. Our result showed that combination of nitric oxide and tubromycin reduce bacterial load in naturally occurring biofilm. First, CF cell cultures were apically infected with 30 microliter of sputum and incubated for 24 hours. Then 10 microliter of 10 microgram per ml tubromycin or PBS added to the apical surface, and cultures exposed to either room air or 10 ppm nitric oxide. Finally, extracellular and cell-associated bacterial load was evaluated, and our findings show that combination of NO and tubromycin was more effective in killing bacteria in naturally occurring biofilm. This is a scanning electron microscopy showing sputum bacteria on the apical surface of CF cell cultures. CF cell cultures infected with sputum show abundant biofilm bacteria embedded in the sputum on the apical surface. Also, there was secreted mucus on the cell surface. CF cell cultures infected with sputum and exposed to NO and tubromycin show less bacteria, and interestingly, there was also less secreted mucus and cilia were readily visible. Summary and conclusion. A low dose of nitric oxide gas generated photochemically by a portable machine combined with tubromycin disperse biofilm and reduce biofilm and viable bacterial density in MPA-infected CF cultures. Combination of NO and tubromycin also reduce biofilm bacterial density in the CF sputum and as a source of natural bacterial biofilm that is specific to CF. Combination of NO-tubromycin attenuates bacteria-induced IL-6, inducing the anti-inflammatory effects. NO treatment improves ciliary bit frequency, and this may be due to the hydration of the mucus. We conclude that treatment with combination of low-dose nitric oxide gas and tubromycin may reduce bacterial biofilm density and inflammation and improve mucociliary function of airway epithelium. At the end, I would like to extend my gratitude to my mentor, Dr. Umar Sajan, who gave me the opportunity to work on this project. I would like also to thank Dr. Meyerhoff that gave us the main idea of this project, Dr. Greg Lutner and Dr. Steven Schwentman for developing the NO machine, and also Dr. Denis Hajiliadis who helped us in sample collection of CF patient. And this project was financially supported via 2 grants, including CFF and NIH grant. Thank you.
We are open for discussion now. Any questions?
Have you tested an IL-6 antibody in this model to sort of test the hypothesis that it is IL-6?
No, we didn't check it.
It would be interesting to do that.
Of course. Yeah. Thank you.
It's from me. Could you discuss a little bit more about the improved hydration that you were referring to? I mean, how does it promote increased hydration?
Actually, we measured the ciliary bit frequency to see the effect of NO2-promycin. After infecting the CF cell cultures with mucus or the bacteria, because of the dehydration of cells, we saw very less level of CBF. After treatment, we saw more cilia, less mucus. It means there's the normal hydration situation in the airway epithelial cell.
So basically, you have an indirect measurement
Yeah.
of what is supposed to be a better hydration of
Yes,
the
correct.
cultures. Okay. David?
Carla, thank you for asking my question. But I didn't know if you guys had ever tested.
We think the same way.
Wow, sorry. It takes a second. Have you ever treated a culture without mucus and no bugs to see how much fluid secretion you're engendering just from NO application? Because that's got to be your dehydration mechanism. That's going to rehydrate the mucus layer, undo the osmotic compression of the PCL, and let things start beating.
Actually, no, honestly, no. But that's a good idea. Thank you for your feedback.
Any other questions?
I will check the app.
He's checking the app.
I have a question. Sorry.
Oh, okay.
Sure.
Yeah, what volume of NO can your machine generate, or what volumetric rate can your machine generate?
Say it again.
What volume or volumetric rate of nitric oxide can your machine generate?
Actually, this machine was assembled in Michigan University. I don't have a lot of information about the function and mechanism of action of this machine. The only thing that I know is that the use of some cartridge is from different kinds of nitric oxide, like SNAP, RSNO, and it can convert to NO. But I don't know about your question. I should ask from the.
All right, thank you.
There we go.
There is a question in the app, and I think it's related to inhaled nitric oxide as a therapeutic. Do you know of any sort of concerns for adverse effects or tolerability with inhaled nitric oxide as a therapy?
Actually, we are in the first phase. Just we measured the effect on CF cultures. We need to work on the mice model. It is our next plan. We ordered some CF mice from Jackson Lab to measure the effect of inhaled nitric oxide. But in this phase, everything was fine. We didn't see any problem.
The cells didn't complain?
No complaint. No cytotoxicity. The LDH level was very less. No inflammation.
And there's, sorry, just because there's a sort of a follow-up in the app, so we're live streaming. Why did you pick 10 parts per million?
Actually, we had optimization for everything. Before we choose 10, we use of different concentration. Even for nitric oxide, we had optimization from 1 ppm to 50 ppm for antibiotic, 1 to 50. We had different concentration, and we found, even for time point, we found 8 hours worked very well, because it's like good for patient during the sleep to use of this inhaled therapy. So even for antibiotic and everything, we had optimization after measuring cytokines and LDH. We choose the best optimized concentration.
Thank you.
It was 10, yeah, thank you.
That was actually my question, was what was the minimum length of time where you see these effects with the exposure to NO? And it says you're saying that it's 8 hours?
Yeah.
That if you go shorter than that, you see.
Actually, we can increase the concentration of nitric oxide. For example, instead of 10 ppm to 20 or 15, not 25. More than 25 ppm, it doesn't work properly in the CF cultures. But by increasing the concentration from 10 ppm to 15 or 20, yes, we can decrease the time. But still, I believe that 8 hours works very well according to our result. Hopefully, in the mice model also, it shows good result, then we can work on 8 hours.
Okay, we are done with this one, and thank you so very much.
Thank you.
Moving along, our third speaker is Dr. Hongyu Lee from Bristol, who will be talking about secretion and alkalization of airway surface liquid from CF bronchial epithelia by artificial anion transporters.
Hi. Here.
So if we hit escape.
We can't see anything. Start. Okay.
I've set the timer for 23 minutes.
Okay.
So it turns yellow after 15.
Thank you very much. Hi. Thank you very much for giving me the opportunity to talk about our project of study artificial anion transporter for CF treatment. Okay, thank you.
It's going well.
Yeah, okay. So cystic fibrosis is caused due to not enough activity of the CFTR chloride channel activity due to more than 2,000 mutations. Several therapies being developed to tackle root cause of CF. Small molecule CFTR modulators are breakthrough in the treatment of CF patients. However, not all CF patients benefit from this therapy due to the variety of mutation. Bypass therapy is an approach to tackle this problem. For example, calcium-activated chloride channels bring chloride across cell membrane, or amphotericin B, which allows chloride passing membrane with other ions. They demonstrate potential of therapeutic value for CF treatment. We have been concentrated on development of artificial anion transporter. There are a group of compounds with lipophilic phase and hydrophilic phase. The hydrophilic phase bind chloride with higher affinities, while the lipophilic phase bind with cell membrane, then transport chloride across cell membrane. We have developed more than 130 compounds with different backbones and functional groups over 20 years. The first question we want to answer was, do ionophores transport anion in living cells? We adapted fluorescence protein-based assay developed by Professor Workman and Gallietta. We used FRT cells that feature thyroid cell expression iodide sensitive yellow fluorescent protein. We incubate cells with ionophores for 10 minutes before iodide was introduced into the extracellular solution. If the iodide can be transported into the cell, we should see quenching of yellow fluorescent protein with the cells becoming dark. This image shows our representative picture of anion transport across the cells treated with ionophores. We can see perfusion cells treated with ionophores with iodide induced a reversible quenching of fluorescence, which demonstrates ionophore does work in living cells. We then adapted this method to use microplate radar with a 96-well plate. We are able to screen
compounds more efficiently and construct dose response easily. This figure shows the result of our experiment, the anion transport activity of more than 20 compounds. We picked up 4 compounds to carry on further study. These are the 4 compounds, 3 declins and 1 trans. For this experiment, we use FRT cells expression both YFP and F508del CFTR. We culture cells at 37 degrees C or 27 degrees C and 37 degrees C plus CFTR modulator, NACFC. We use phosphocoding to activate CFTR activity. We can see the correction with either 27 degrees C or NACFC enhance the F508del activity. On top of this, if we include CFTR potentiator avacaftor, we can see activity increase further. Okay, it's quicker. So, however, on top of this treatment, we added 4 compounds, and we observed all compounds enhance the activity of the cells further. That gave us idea about ionophores are additive to CFTR modulators. So that we move on to next step. We want to find out whether those compounds work on CF bronchial epithelial cells. We use a CB41O minor cells expression YFP. We observed that using these cells, compounds 11, 12, and 19, the dose responses are more or less similar to what we observed in FRT cells. However, the potency of compound 15 reduced. That suggests the poor deliverability of compound 50 might respond for this reduction of activity. Then we want to find out whether compounds can actually work on CFB bronchial epithelia instead of cells. In this case, we focus on these 3 compounds. They share the same backbone, but differs in their functional groups. And this time, we used a microplate radar to test activity instead of a conventional Austen chamber experiment. So because that is the first time to use microplate radar to detect anion transport across epithelium, we did a validation. We seed cells into the 96 permeable supporter on the filter, and we culture cells, so like this. The medium basing apical site and basolateral memory site can be changed separately. For the validation, we choose to use cells, the FRT cells co-expressing YFP and either Y-type CFTR or delta F508 CFTR. So cells culture in the filter for 5 days to form higher polarized epithelium. Then we added the CFTR modulator, ETI or vehicle, to the apical site, then cultured for 24 hours, then using phosphocoding to activate CFTR before we measure activity. So the representative traces and the summarized data demonstrate that the data we collected with this method consistent with what we observed previously by using Austen chamber technique or using patch clamp technique, that the Y-type CFTR had a greater activity than delta F. With CFTR modulators, ETI, the activity of Y-type and F508del all boosted further. Now, it's safe to move to the CFB epithelium. So 2 days after CFB cells were seeded into a transwell insert, we removed the medium on the apical side to achieve air-liquid interface, and the medium basing the basolateral membrane side were changed every other day, and any liquid in the apical side also being removed every other day. 3 weeks later, the epithelium formed with higher transepithelial resistance. Then we added medium containing either ionophore or vehicle back to the apical side. After 1 hour incubation, we removed the medium, and the activity of ionophores were detected by using microplate radar. So these representative traces and summary data indicate all 3 compounds generate larger ionine transport in comparison with the control. Then we compared the activity of the ionophore in epithelium with what we observed from the CFB monolayers. We can see the rank order of potency of the compounds are the same in either monolayer or epithelium. However, the amplitude of the activity reduced in epithelium due to maybe reduced deliverability of the compounds into epithelium. Nonetheless, we observed ionine transport 2 days after incubation. The epithelium with the compounds for only 1 hour. So that suggests the consistency or persistency of the ionophores in CFB epithelium. So we consider ionophores is able to transport anion across CF bronchial epithelium. Next step, we want to find out whether ionophores stimulate A cell secretion. So in this experiment, we used midi cells to culture cell B cells because midi cells got a larger surface area, enable us to collect enough solution to do the measurement. We also included blank midi cell with no cell seeded as a control. So we measured the volume of ASL and transepithelial resistance before and after 2 days, 2 days after the incubation with ionophores. The data suggested here, we can see that all the medium, all the 12 and 15 cultured epithelium got a larger volume of ASL. However, the amount of compounds 11 managed to do is much smaller. Nonetheless, we can see all the volumes collected from epithelia is smaller than the volume of the blank one. That suggests the volume we measured is likely to be secreted by the epithelium, not through leakage of the damaged epithelium. To monitor integrity of the epithelium, I think I need water. Epithelium, okay. So we measured transepithelial resistance. 2 days after the treatment with ionophores, we can see the transepithelial resistance. Oh, thank you very much. The transepithelium resistance are higher or larger than the blank one. That suggests the intact of epithelium in the presence of the ionophores. which also suggests the liquid we collected is more likely to be a secretion from the epithelium rather than leakage from the membrane. So then what's the next step? We want to find out whether an ionophore can affect pH of ASL. As we know, alkali's pH of ASL is important for bacterial killing. Using the micro pH meter, which is sensitive to measure volume as small as 50 microliters, we measured HL, pH before and 2 days after treating the treating the epithelium with either an ionophore or vehicle. As a control, we also measured medium containing either vehicle or the major tested compounds. Compared with vehicle, these three compounds didn't affect pH of the medium. Then we can run to see what we have got 2 days after treating the epithelium with an ionophore. We can see all three compounds increase the pH of ASL, then suggest an ionophore might affect or might mediate secretion of bicarbonate by the CB epithelium. Then that's the next step. After we found out the benefit an ionophore brings to CB cells, we also want to find out whether it can damage epithelial cells as well. So using XTT technique, we tested cell variability of the epithelium, CB epithelial cells. So 1 day later, we didn't see great effect of the ionophore treated epithelium. So there's no effect or small effect, not significantly in comparison with a control, which is a 1. However, 2 days later, some toxic effect appeared with compounds 12 and 15. Therefore, we consider that compound 11 is non-toxic. However, 12 and 15 demonstrate some toxic effect 2 days after incubation. In conclusion, we think tackling ionophores are deliverable to culture safe bronchial epithelia. They mediate anion transport, stimulate ASL secretion, alkalize ASPH. However, some compounds show cytotoxic effect. Nonetheless, we consider an ionophore have potential to be developed further for CP treatment. Thank you very much.
We'll open the floor to questions.
Two questions. First is, do you know whether this distributes to apical versus basolateral membrane? And the second question is, can you isolate the ions that are actually transported by manipulating apical and basolateral media?
So first question, I think that's a very good question. We did try to track where the ionophores goes after you deliver to the apical side of membrane. We try to attack fluorescent signal with an ionophore. However, that affects the movement of an ionophore. We still haven't got any success in that. Another problem with that, because we're using the fluorescence-based assay, other fluorescent compounds interrupt with the detection system. So we did try, but didn't get any progress there. The second question was that about the basically.
Can you isolate which ions are being transported that lead to these results by manipulating the ionic content of the apical and basolateral media?
We did try to see which kind of anion can be transported by ionophores. In our experiment, nitrogen was the most potent thing to be transfected or transported, and iodide. However, they doesn't transport sulfate and also transport other things. Yeah, but mainly chloride, iodide, and nitrate.
Hi, I have a couple of questions also. First one, I didn't get, how did you measure cell viability?
Oh, XTT.
Okay, fine. I wasn't sure if you're using a fluorescent dye. I was wondering if the dye may have gone through the ionophore, but that's not relevant. Then the other question is, to get chloride secretion and ASL secretion, are you activating a potassium conductance as well to get a counterion to flow out? Do you know?
No, we didn't.
Do you think, because if just chloride is going out, you get a buildup of charge?
Yeah, but in this experiment, iodide is moving.
Okay, fair enough.
So the iodide in, chloride out.
But no, I was talking
balance
for the
charge.
ASL height experiment. For the ASL secretion experiment, there's no iodide, right?
Yeah, in that case, no iodide. So that
Sorry,
might explain why the result is what I expected, particularly the compound 11. I tried several times, didn't see any further increase of the secretion of ASL. That might be the cause because you didn't manage to the balance the charge.
Yeah, okay, thank you.
Yeah.
Okay, and there are no questions in the chat. Any other questions from the audience? Okay, thank you again.
Okay, now we are going to the fourth talk, and it is my big pleasure to invite my colleague, Scott Donaldson. He's going to be presenting data on the effect of discontinuing hypertonic saline or Dornase alpha on mucociliary clearance in ETI treated people with cystic fibrosis. And this is a simplified MCC study.
What do I do?
Click on your name, and it should. Oh, and then start.
Oh, start. Thank you.
There you go. And you can move the microphone up.
I failed the intelligence test already. Sorry. Thanks for the opportunity to present. Thanks for coming. Somebody had to have disclosures, so these are mine. Now, if I can just get the slides move. Jeez. Do it the old-fashioned way. Okay, so today I'm presenting on behalf of the Simplify Mucociliary Clearance Study team, in which we studied the effect of discontinuing hypertonic saline or Dornase alpha on mucociliary clearance in people with CF who are being treated with elexacaftor, tezacaftor, or ivacaftor, or ETI. So I'm going to start with my thank yous first while I have your attention. First to the CFF for funding this work. Also to the TDN Coordinating Center and to the Simplify principal investigators. This study that I'm presenting today was a sub-study within a much larger study. So thank you to Nicole Meyer-Hamblett, Dave Nichols, and Alex Skifford, and particularly to the MCC study teams who got this study done. So my colleague Bill Bennett at UNC, Tim Corcoran, Joe Paluski at Pittsburgh, Beth Lauby, Peter Mogazel at Hopkins, and Steve Rowe at UAB. So as people with CF are being treated with highly effective modulators, they're certainly experiencing significant health benefits, fewer symptoms. And they've expressed a real desire to simplify treatment regimens as a result. And so this need is what drove the design of the Simplify study. And this study was designed to test a hypothesis that we can actually take away either hypertonic saline or Dornase alpha, and that it would be safe in people once they're on ETI therapy. And so to do this, we actually performed 2 parallel studies where patients were randomized and it was controlled, and we looked at and compared people continuing or discontinuing either hypertonic saline or Dornase alpha. The treatment period within these studies was 6 weeks in duration, and participants had to be at least 12 years of age. Adult participants had to have a minimum FEV1 of 60% of predicted, and children had to have a minimum FEV1 of 70% of predicted. This was a rather large study with 847 randomizations into the study, including in 672 unique participants. Some participants would finish one study and then roll over into the second. And these data from the core study were already published, and the key finding was that stopping hypertonic saline or Dornase alpha did not result in any meaningful differences in lung function in the participants who had very preserved lung function. So the mean FEV1 in these studies was 96.9% of predicted. And so you might ask, why would we bother to build the sub-study within the core study where we measured mucociliary clearance? And really there were several reasons. The first is we anticipated that we may see trends in lung function or outright differences, and having an orthogonal set of data with a physiologic endpoint would really help us to understand and bolster any conclusions that we might derive from a relatively short-term experiment. Second, clearly, mucociliary clearance is directly relevant to the mechanisms of action of both hypertonic saline and Dornase alpha, and also actually captures a primary effect of ETI therapy, which accelerates mucociliary clearance as well. And then finally, we predicted or expected that mucociliary clearance measurements may actually be upstream to the eventual mucus accumulation in airways, mucus obstruction by PFTs, symptoms, even exacerbations. And so by measuring MCC, we might have sort of a physiologic red flag to be able to capture a deterioration in lung physiology before we might even see a clinical change. So this was the overall Simplify study design. In it, patients were clinically prescribed either hypertonic saline, Dornase alpha, or both. They then entered a 14-day wash-in period where their adherence to these medications was assessed. If they were adequately adherent, patients on dual therapy were randomized either to the hypertonic saline study or the Dornase study, and patients on monotherapy went into the appropriate study. We then made measurements of mucociliary clearance at baseline, and then they were then randomized to either continue or discontinue therapy, and then we brought them back 6 weeks later to make a second measurement of mucociliary clearance. So if you're not familiar with this assay, it was performed at 4 qualified MCC sites using a standardized operating procedure. Very briefly, we do this by first performing what's called a transmission scan. You can think of it as sort of a low-resolution chest X-ray. And we do this to allow us to define the lung borders and also to define particular regions of interest, but including a central ROI, which is relatively enriched with large airways, and a peripheral ROI, which is relatively enriched with small airways. Participants then inhale a technetium-labeled sulfur colloid solution using very defined breathing patterns that allows us to relatively consistently deposit these particles in the airways. We then place them in front of a gamma camera where we obtain serial 2-minute gamma images over time. So after doing background subtraction and correction for isotope decay, we can then plot these retention versus time curves from which we calculate average clearance rates. So this is the baseline demographics of the patients who entered these studies. We enrolled a total of 34 patients, 17 into each study. It was quite balanced in terms of gender. You can see the age, about 25 years. Again, would like to point out that patients entering these studies had quite mild lung disease, so 88% baseline FEV1 in the hypertonic saline study, 93% in the Dornase alpha study. Also would like to point out that the majority of patients who entered either study were also using we'll say, alternative therapy. So in the hypertonic saline study, 88% were using Dornase and 82% were using hypertonic in the Dornase study. A minority were positive for Pseudomonas by culture in the prior year. And again, and finally want to point out there was a by chance inequality, or I'm missing my words here, in the number of patients who are allocated to discontinue versus continue Dornase alpha in the DA study. So only 6 patients were allocated to the discontinue arm. These are the lung function results, and I'll kind of do this quickly. Both spirometry, so FEV1, and lung and multiple breath washout, so lung clearance index, were measured in these groups. And just to cut to the chase, we saw no significant differences in either FEV1 or LCI in the continuation group, discontinuation group, and either the hypertonic saline or the Dornase study, much like or exactly like what was seen in the larger parent study. So this was the first slice of MCC data that I'm showing. On the left, I've plotted the change in mucociliary clearance in each group, so the discontinue group and continue group, so that you can compare between groups. And on the in the middle and the right are spaghetti plots where I've plotted whole lung mucociliary clearance at baseline and at the end of the 6-week period, in the middle in the discontinue group, on the right in the continue group. So suffice it to say, withdrawal of hypertonic saline did not lead to any between group differences in terms of the change in MCC, and we saw no changes from baseline in either the discontinue or the continue group. In contrast, in the Dornase alpha study, we did see a quite significant difference between in the change in mucociliary clearance in those who discontinued versus continuing therapy. And the surprise was, in fact, the improvement favored those who stopped Dornase alpha. And we can see by looking at the spaghetti plots of whole lung clearance baseline versus at the end of treatment, that this was driven by a real improvement in mucociliary clearance in the discontinued group, whereas we saw no change in those who continued therapy. So I'd like to put in some context. What does a 6% absolute change in MCC mean? It means something to me, but probably not to you. This is as big or basically identical or perhaps even a little larger than the sustained effect of hypertonic saline on mucociliary clearance in adults not taking ETI, so comparing to historical data. So we believe that size effect is clinically meaningful, so we would make the argument at least that this is potentially a clinically meaningful effect as well. We kind of drilled down a bit more to understand where in the lung these changes in MCC were occurring. As I mentioned at the beginning, we can look at the central region of the lung, which is kind of large airway enriched, peripheral region of the lung, which is small airway enriched. And what we found is that almost the entire effect was really being driven by changes in the peripheral lung, so the small airways, where again, this is a change in now peripheral lung MCC favoring those who discontinue with a significant improvement in MCC in that peripheral lung region, no change in those who continued therapy. So we went on to perform some sensitivity analyses, and MCC data can certainly be affected by a number of factors, including the pattern of radio aerosol deposition, infection status, et cetera. And so through these analyses, we determined that, in fact, there was no effect of the radio aerosol deposition pattern, sex, age, Pseudomonas culture status, baseline lung function, genotype group, or whether or not you're using hypertonic saline at study entry. And so our kind of high-level summary conclusion is that discontinuation of either hypertonic saline or Dornase alpha did not result in deterioration in mucociliary clearance over a 6-week time period in these people with CF who had relatively preserved lung function. And in fact, we saw significant improvement in both whole lung and in peripheral lung MCC after discontinuation of Dornase. So that certainly leads us to speculations. Why did this happen? The first thing that really, we know that after ETI therapy, many things change in the lung, including mucus properties, percent solids, other biophysical properties. But the parallel experience that really came to mind is that in patients with non-CF bronchiectasis, when they've been treated with Dornase alpha in clinical trials, they also had worse lung function, higher exacerbation rates in a relatively large study over a 24-week treatment period. And in a separate study, it's been published that in vitro sputum transportability was also reduced after Dornase alpha therapy in patients who were treated with 2 weeks of Dornase. So seems to be a parallel that perhaps we're uncovering now in ETI-treated patients. It also suggests that we have to really rethink how what we know about efficacy and safety of standard CF drugs in the post-ETI era. Everything that we've tested previously came before ETI, and now we may have to rethink that in this new world. Our study certainly had limitations, most importantly, perhaps, the small sample size, especially in that Dornase discontinued group, and also the very limited range of lung function that was really limited to those with quite mild lung disease. So that would drive us further to really want to further assess both Dornase and osmotic agents, hypertonic saline, dry powder mannitol, and their effect on mucociliary clearance in patients with more severe disease. So I think that may be the even more pertinent clinical question of whether these therapies are additive, neutral, or perhaps even harmful. And this is maybe a bit tangential, but when I look at these, the data and the experience of seeing an unexpected treatment response, can we actually use mucociliary clearance or other phenotyping endpoints to now identify subgroups of patients with CF and other diseases, particularly non-CF bronchiectasis, where we can identify those that have similar treatment patterns and then put them into pooled studies where we can then accelerate drug development. So with that, I'll close it and open it to questions. Here comes the tall guy again.
Please raise the microphone.
Oh, that was perfect when he kneels.
Scott,
Okay, that's awesome.
As I'm sure you're aware, I'm not going to propose if you're here. In the original Brandt study, they found that Dornase alpha was most effective in patients that had a high molecular weight DNA component to their sputum. Has there been any follow-up analysis in Simplify to see if that band's gone for the patients that can go off Dornase alpha safely?
Yeah, I know it's a great question. Certainly, that's what crosses our mind as well. We did not measure, we actually did not collect sputum in Simplify. Certainly, there have been other opportunities to assess the effect of highly effective modulators on sputum constituents, especially in the PROMISE study. I don't believe we've made any DNA measurements in PROMISE, but that certainly would be an opportunity to think about with bank specimens. Dr. Schmiel.
Hey, Scott, thanks. Great talk.
Thanks.
Question, this is a 6-week study. Do you think in a longer-term study, the results might vary? Because certainly in my experience before ETI, after ETI, patients often stop for 6, 12 weeks or more, or wait till they get sick to start some of these therapies. And is 6 weeks long enough? And do you think it could change if this is a longer term?
I think it's a totally fair question. The short duration of the study was why we wanted to add this endpoint for starters. But certainly you can think that as things change, these therapies may come back in play. And so, we could think about both longer term studies, but also, at least in my clinic, it's
perhaps these therapies are using more episodically as well. So they get sick and they want to layer something back in. So, do they work in that situation? We don't know. So I think it's totally a fair question that we need to think more about. Imano?
I think your second answer sort of assesses or responds to my question. Do we know anything what happens around exacerbations to MCC? Is there pathophysiologic context or rationale for using it? Because as you said, patients are often using it as needed now.
Yeah, thank you for that question. It's a little embarrassing that I've been sitting on data for about 12 years on that topic. I blame Rick Boucher for not. No, it's
He's
been.
not here.
Yeah, he's not here, so I can say whatever I want, right? Is this being recorded? No, we have actually another small study, but pretty rich data set examining exactly that. And I'll just tell you the unpublished result, hopefully that'll change very soon, is that mucociliary clearance does in fact plummet at the start of a pulmonary exacerbation, and is actually appears to be fairly slow to recover. So that may be an ideal time to again reassess some of these therapies.
Hi, Vamshi Raju from University of Alabama. 6% change in MCC is huge. So do patients actually feel the difference, and can you quantify that?
Probably not, particularly where these patients are starting from. I think they're starting from 90% lung function. Many of these patients don't have a cough or any pulmonary symptoms whatsoever. So, the nice thing about MCC is we can see responses at all ends of the spectrum. So people have 30% lung function that are sick. We can see upwards and downwards deflections. People who have normal lung function and no symptoms, we can see upwards and downwards deflections. But so it probably depends on where you're starting from and how sick you are. Certainly not in this study. I would not say that our patients told us that that they felt better by stopping Dornase, for example. And I think our CFQR data in the Simplify study would speak to that as well. Most people are pinged out as no symptoms.
Okay. Was that a conscious choice to use people with preserved lung function?
There was decisions made based on safety. We did not know what was going to happen, so taking away these therapies that we know have been very important for people with CF for a long time. We want to be conservative, not come in with people with 30, 40, 50% lung function and take away therapy. So there was a conscious decision not to go too low. But our inclusion criteria were broad enough that we could have seen a higher range, but it's just that patients who chose to enter the study had very mild lung disease.
Thank you.
Yeah.
Hi, great presentation. Any changes in infection?
We did not measure that in our MCC study. I don't think we did not measure that in the overall MCC study as well. I think, again, it's a short treatment period focused on hypertonic saline and Dornase. I think the better data has come from the PROMISE study of looking at the effect of ETI.
Thank you.
Yeah.
There is a question in the app, and I also have a question. Thanks, Scott, for the provocative data. It's really, I think, turning a lot of wheels. So the question in the app first is, have you seen any evidence of waning efficacy to these therapies in that chronic treatment looks similar to those discontinuing because the actual effect was after initiation? And are the MCC results sustained from first administration to much further out? Like, that? Or do they wane over time, and that's why it's similar to just discontinuing?
That's a complicated but great question.
Yes, reading that on the fly was, yeah.
Maybe they're passing. Yeah. No, I'm joking. What can I say about this that's true and meaningful? I think with ETI, we do know that those effects are very sustained when we look at 1 month versus 3 months. We've not gone longer than 3 months. So we see absolutely no difference of ivacaftor in G551D patients studied over that time period. What can I say about hypertonic saline? Any studies of hypertonic saline using mucociliary clearance have been on the order of 2 weeks. And so I can say that over that time period, it's a sustained effect. Beyond that, I can't put my hand over my heart and say that that it just goes away. But I don't think we have any indication that that's happening. That's fair.
Thank you. And my question is, are these MCC results trending to, when you see improvement, it's trending towards normal, but are there normative data? Is it normalized or normalizing?
Yeah, you can imagine I've had this question before. It's a complicated answer, and what I would love to say is that people with CF have low MCC, and it gets better with therapies that address that defect. The reality is, at least in our hands and in our multi-center experience, is that if you use the same MCC technique in a group of healthy volunteers and a group of patients with CF, we can pick out some defects that are worse in CF, particularly peripheral lung mucociliary clearance. But clearance in large airways and whole lung clearance tends to be pretty normal. When you take a group of CF patients with varying lung function, you actually see the opposite of what you might predict. People with CF who have preserved lung function, little kids with CF, they probably have the slowest looking MCC. But when you look at people very sick with 30% lung function, severe disease, they will have the fastest apparent MCC. And the reason relates to where the isotope is being deposited. So if you have a lot of airways disease, we put a lot more isotope in central airways, which clear faster. If you have a normal lung, you put the isotope deeper in the lung, so clearance looks slower. And so it's very hard to make these sort of comparisons between different disease groups. So I always avoid doing that.
Hi.
Last question, Maggie.
Yes, simple question. What are you telling your patients to do now with the results?
Well, when I go to clinic, the thing that drives my advice to patients comes from the larger simplified study. And in the size of that study, the data that was obtained from it makes me very comfortable in people with mild lung disease that it's okay to try to stop these therapies. And I would say that, I know Jim mentioned, patients who stop and then go back on. In my experience, most patients who have few symptoms while they're on ETI do very well stopping their therapy, and I've not personally seen much in the way of negative effects from stopping therapy. I think when we get into patients who have more severe disease, we're into unknown territory again. And we only, unfortunately, had a very small number of kind of severe disease cohort that got studied in Simplify. And it's a question that needs to be addressed. My personal approach is talking to the patient and hearing what they want to do and what they want to try. I put a fair bit of weight on their symptoms. Do they have cough and sputum? If they tell me I never cough and I never produce sputum, I'm a lot more comfortable saying go ahead and try stopping these things. If they come in and say I'm coughing up sputum each day still, even little bits, I'm much less comfortable. So that's, you heard my personal approach for what that's worth.
Thank you so much.
Thank you.
And our last speaker is Dr. Carlos Mila from Stanford, who's going to talk to us today about mucus clearance therapy by an innovative synergistic approach, early phase 1 study results. The title leaves us hanging.
Well, you're right. You cannot see a thing. I hope I can read my slides here.
And then start. There you go.
There we go. All right. It's a real pleasure, and thank you to the chairs for inviting me to present our work and speaking on behalf of my colleagues and co-investigators at Stanford. This is purely a Stanford product. How do you do the... It's acting. It's acting. It is really funny. Oh, there we go. Okay, just really quick. I also am a very conflicted individual, but it's hard to do these things without money. So it's great to be the last speaker. I don't need to elaborate on what CF is all about, how important mucociliary clearance is, but we're very focused on the fact that we know that addressing mucus retention in the lungs is an important aspect of CF care. and certainly coming with better ways to improve that mucociliary in people with CF, particularly those who are not eligible to modulators, is still very major unmet need. And we also know that this will include people with CF that even on modulators, they are still experiencing symptoms or have advanced disease, as well as children that are still not eligible to modulators due to the label indication. So our hypothesis, and this builds on many, many years of work, particularly work done at the bench by Jeff Wine and Nam Soo Ju, is that a combination of cholinergic and adrenergic agonists, where we have labeled the synergy paradigm, that was identified through bench work. And we have not just ex vivo, but also in vitro and animal work behind this, that we can translate it to human use to improve the mucus obstruction that is characteristic of CF lung disease. And very briefly, as one snapshot of what this is all about, and I'll invite you to go to poster number 164, which Namsu is updating us on all of the basic science behind this. He started by doing ex vivo experiments with tracheal preparations. And what you see here as, these little black dots are ink dots that are placed on the tracheas, and we have these raised tracks, and we see, how which of the tracheas is moving the ink dots faster, and that's what gives us a readout of what we call mucociliary clearance velocity. And with this, working with wild-type animals or CF ferrets or in pigs, what we've shown is that if you use either cholinergic or adrenergic agonists alone, there's some movement of the mucus, there's some velocity in the transport that you induce, but when you add both together, you get a major acceleration in that mucus velocity. And that's reflected on these two graphs, and you see again that on a wild-type background, as well as on a CF knockout background. And what we're showing here is that, again, if you add the responses that you see with either adrenergic or a cholinergic agonist alone, which will be just what you can call just the sum of the two responses, is not what you observe. It's a much larger response in the velocity of the transport, and that's why we call it a synergy paradigm. What we propose as a mechanism of action is that there are several things that are going on at the same time. The adrenergic pathway is probably and mostly probably mediated through CFTR, inducing chloride and bicarbonate transport, that's well established. And the cholinergic pathway, we think that is inducing through most likely alternative chloride channels, chloride transport, but at the same time is also decreasing the activity of the sodium channel, and that then is what is going to lead to this synergistic response that primarily is, from what we are already seeing in our in vitro data, related to ASL changes. But at the same time, we have the advantage to also be inducing increased ciliary beat frequency, and then putting all these mechanisms together, what you're orchestrating is a major increase in the mucociliary transport. And I should also mention that you need to think about just normal physiology. You have both pathways active in your airways, so it's more likely that you resort to these mechanisms when you need to respond to a stimuli that needs to increase the transport of mucus. So last year at the NACFC, we give you sort of a preview on one of the symposia to the work that we were doing in trying to advance this to the clinic. We did a small pilot study on healthy volunteers with a short-acting bronchodilator, meaning albuterol. And we were able to demonstrate that in combination with methacholine, which was our selected cholinergic agonist, we saw that there was good tolerance, and that gave us confidence to then keep moving forward to the study that I'm presenting today, where we designed it as a phase 1, mostly safety and tolerability study. That was our main goal, with both healthy volunteers and people with CF. And the study was designed as your typical phase 1 single ascending dose in 3x3 blocks for the healthy volunteers and 6x6 with the people with CF. Primarily to make sure we were not missing on a safety signal, and also to add some exploratory endpoints to give us some feel for whether we were going to get to a potentially clinical translation of benefit. And obviously the healthy volunteer study was completed first, and after DSMB review, we proceeded to the CF study. And with 4 dosing cohorts that were delineated. And again, each cohort had, for the healthy volunteers, 3 people, and for the CF study, 6. And these were the doses that we use, methacholine at 20 micrograms, which is the FDA-approved dose. And then translating in part from the in vitro and animal work, we selected these doses of methacholine. The study drug was administered by nebulization with a pari E-flow, and the primary objective, again, was to assess safety and tolerability. And this to come up with, the ultimate goal, identify a maximum tolerated dose to a single dose. And the secondary objective was to explore potential readouts, of clinical benefit through lung function as well as sputum parameters. Our entry criteria was fairly standard for this type of studies for the healthy volunteers, and these studies were done only in adults, so we wanted people older than 18 without a history of lung disease or respiratory disease. That were agreeable to the study procedures, plus being non-smokers. CF was similar, but with the addition that we needed to have them well proven in their diagnosis of CF, as well as their FEV1 being greater than 40% predicted, and that primarily for safety reasons, as well as to be exacerbation-free for at least a month. In terms of the study procedures, subjects came for a baseline evaluation that included a symptom questionnaire, a review of concurrent medications, which was more relevant, obviously, for the people with CF, as well as assessing vital signs and pulse oximetry. And we incorporated multi-brush washout to measure LCI and spirometry to look primarily for the presence or the eliciting a bronchospastic response, given the methacholine doses that we were using. So it was primarily a safety parameter, why we use the spirometry. Then at time 0, subjects received the study drug, and then every half an hour, we reassess their vital signs and their spirometry. The pulse oximetry was measured continuously throughout a 2-hour period. And then at 1 hour, we elicited sputum production. We used the sputum induction procedure with the SOP from the CFTDN. And then at the end of study, we reassessed spirometry, and we did a second multiple breath washout to assess for LCI. These are the characteristics of our cohort. We're able to enroll 38 individuals, 13 healthy volunteers, and 25 people with CF. We have 1 screen failure on each of the study groups, and this was due to high blood pressure. They all met entry criteria, but 2 people had high blood pressure, so they had to be excluded. The age was slightly younger in the CF, which was expected. We had older patients coming for our healthy volunteer cohort. There was a slight predominance of females in our healthy volunteer as opposed to CF, and a slight predominance of, or at least I'll say we have more Asian individuals on our healthy volunteer cohort as opposed to our CF cohort. And we have a fairly similar distribution or proportion, I'll say, of Hispanic individuals as opposed to non-Hispanic. Now, of real importance for our current state of affairs with CF, about half of our patients were homozygote delta, 28% were heterozygote, and 24% were non-delta mutations. But of high relevance, all of the patients who enrolled, and this was just by chance, happened to be under treatment with highly effective modulators, the majority of them being on Trikafta. In terms of lung function, and I'll say most of these patients were at least for over a year on treatment. Many of them had been for many years on highly effective modulators. So first thing that came, not surprised really, given the age of the individual and the treatments, is that the spirometric parameters are fairly comparable between the healthy volunteers and the CF cohort. Most of them have fairly normal values of lung function and very mild evidence for airway obstruction. Where we saw the big difference is on the multiple breath washout. There were multiple parameters that we assessed, but both the LCI 2.5 and the LCI 5 which probably most of you are familiar with, were highly different between the CF and the healthy volunteer cohort. You can see that the LCI was almost double what we were seeing on a healthy volunteer. And this basically tells us about the silent aspects of CF lung disease that are still present on people treated with highly effective modulators, meaning the FEV1 is not telling us the story. We're going to totally miss it unless we do more sophisticated things at the LCI. And this we see as reflecting the presence of probably peripheral, I don't know if I'll call it airway disease, but at least peripheral mucus obstruction. Now, quickly to go through the results for the healthy volunteers, we basically did not see a signal for safety or intolerance in the FEV1. Most subjects either maintained or had mild improvements, increases on their FEV1, and this is the percent change in FEV1 in liters. We're not using percent predicted here, since in part because they're all adults. So no one met the criteria for intolerance. The drug across all doses was well tolerated, not just by FEV1 criteria, but also by vital signs and by report of symptoms. And then the maximum tolerated dose was the highest dose that was tested. With this, we then look at our sputum parameters as an exploratory endpoint, and basically we saw no differences. But, we were able to get sputum out of all of these people by our sputum induction protocol. Interestingly, on the spirometric exploratory endpoints, we saw some interesting trends for a almost dose-response type of relationship on FEV1 to FVC ratio and to FEF 2575. Again, owing to the very small sample sizes, not surprising that we're not really hitting statistical significance, but we're seeing some interesting trends. So with this, we move to our CF dosing cohorts. And again, we started with a cohort with formoterol alone and escalating to a high dose, which is the 12 micrograms of methacholine. And on none of the cohorts, we saw something that was or was interpreted as intolerance to the drug. Only in the last cohort, we have one subject, which happened to be our last subject, that had an intolerance to the induced sputum. However, this subject had fairly stable FEV1. I think, if anything, was slightly just a 1% or 2% higher compared to baseline, 30 and 60 minutes after the study drug administration, but had a reaction or, let's say, a discomfort with the sputum induction, and then we had to stop. Now, this is the overall trends in the FEV1. Again, no real statistical significance here, but you can see is that on our active, or let's say combined adrenergic, cholinergic dosing cohorts, we saw no patients meeting criteria for intolerance. And if anything, we saw less variability on our patients that received the highest doses, with small increases on the FEV1 in the order of 3 to 5%. In terms of other exploratory endpoints, the FEV1 to FVC and FEF 2575, we did not really see any statistical significance or clear trends, owing probably in part to a high variability. The median values, if anything, there's some numeric differences there, but no real statistically significant trends. And for the LCI, we also saw very high variability, particularly on the people that received the highest dose. And interestingly enough, the largest decreases, and remember, in LCI is the opposite of FEV1, the lower you go, the better your lung function is getting. And we saw the largest decreases in LCI in the people that were receiving the cholinergic agonist, with no real dose-response trends. Now, in terms of sputum, believe it or not, we were able to get sputum on these people being treated with Trikafta. And we noticed some interesting trends where we saw highest volumes of sputum produced by the people on the cholinergic agonist, particularly on the highest dose, though we didn't hit statistical significance. And in addition to just checking the actual sputum weight, we also dehydrated it to look at solids content. And that's where, interestingly enough, we saw a statistical significant difference where there was a much higher sputum solids content in the people that received the cholinergic agonist as opposed to the people that received only the formoterol control. And we think that this is probably reflecting a true mobilization of mucus plugs, meaning real thick stuff as opposed to simply watery material. So in summary, We think that the combination of beta-adrenergic and cholinergic drugs has great potential to increase mucus clearance. It's what we call the synergy paradigm. And certainly that the simultaneous administration of the combined drugs preserves the synergistic effects on mucus clearance without inducing bronchospasm. That was our main concern here, where we're going to see bronchospasm abrogating the positive effects. And what we think is happening, and we can have a good conversation about this from a physiologic perspective, that formoterol, by at least two different mechanisms that can come to mind right now, protects from muscle contraction that could be induced by methacholine. And the effects in sputum are, we think, very interesting with just acute dosing in the CF subjects. And the early human data is certainly supporting, in our view, the safety of the approach and moving into larger trials to put this to test. Now, I would like to thank the Stanford Innovative Medicine Accelerator Program. This is our main source of funding for this study. And I certainly have to thank to my fantastic team at Stanford, both the clinical and the research team. We do a lot of bench to bedside and bedside to bench and all the way around. And without them, it would have been really hard to be able to do this, particularly taking into account that part of the work was done as we were trying to recover from the pandemic. So thank you, and I would love to hear your questions.
So, hey, Carlos, it's Jim Schmiel.
Yeah.
So thank you for a great presentation. So a couple questions I'm trying to wrap my head around. So we really only have experience clinically with methacholine as a diagnostic. We use it one time. We really don't know what happens when you give it multiple times continuously. And then also, use of a LABA without an inhaled corticosteroid locks down the beta-2 receptor and downregulates that beta-2 receptor. That's why the drug companies always say never give a LABA without an inhaled steroid because of what happened to the asthmatics. Are you concerned, given that 1/3 of our CF population has asthma, whatever that is, that the long-term use of methacholine will eventually, in those individuals who have a proclivity towards airway reactivity, induce a bronchospasm, and then now the formoterol has downregulated the beta receptors, and your ability to respond to a bronchospasm is going to be lessened because of the tachyphylaxis that happened with the addition of a long-acting beta agonist without an inhaled steroid?
Yeah, those are excellent questions, Jim. I should mention that some of these individuals had a diagnosis of quote-unquote asthma, and we did have them part of the
Microphone's that one. That's the light.
Mark uses this one. Okay. So part of the entry criteria, let's say preparation criteria, was also to have them off a list of different inhalers prior to coming to the study. But I think these are excellent questions that we're going to have to address as we move forward into doing additional studies. At least from the animal data, we're also not seeing signs of reactivity. But again, we need to move into repeated dosing studies. What is limiting us is obviously the fact that, we're going to have to come up with ways of making a formulation that then we can put to a repeated dosing type of exercise, and that's sort of our next step.
Thanks.
So I had two questions. Jim sort of asked one of them, so I'll come up with a third question. Just lost my brain. So one of the hypothesized mechanisms was behind the llamas is that they may increase acetylcholine in the junction, increase secretion that way. Have you considered the llamas in this instead of methacholine? And the second question is, do you think that these data might be fundamentally different if it was people who were not on ETI?
That's a great question. I can tell you our initial intent was to try to at least have a good number of non-ETI people, but as opposed to our perception, I call it, we saw low interest in the people not on ETI, and the people on ETI were the ones who were interested. It totally stunned me, to see that. So, but yes, we'll have to do those studies in the people not on ETI. And to your question about llamas and lavas, and the only thing I can tell you is and we'll have to do more studies, certainly, both ex vivo and in vivo, but at least from animal studies, intact sheep studies, what we've seen is that if you block the CAGs, you see a decrement in mucociliary transport.
Thanks. Really cool talk. I know you mentioned at the end that with the increase in percent solids, you think that it might be mucus plugs that you're recruiting. Do you think that there might also be a component of that is submucosal gland secretion that you're recruiting? And do you think that there's a way that you might be able to distinguish the two if that's the case?
Yeah, that's an excellent question. Unfortunately, because of how we designed the study and the fact that it was a challenge to get all these samples, the only thing that we did with the sputum was simply do the desiccation. But that's on the to-do list, to actually collect those specimens and do more like a rheology type studies, and also try to look at the different mucins that are present and see that helps to distinguish, how much, because at least from the animal data, what we're saying is that there is a role of the glands in all this. You need the glandular activity to get to this increase in the mucociliary transport. And we all probably have that response naturally. But we're going to have to do more studies and look more carefully at the actual mucus being mobilized to get at this.
Awesome. That'd be sick. Thanks.
Hi, Carlos, great study. John Dickinson from Nebraska. I guess in mice, methacholine induces massive secretion of intracellular mucins. And which is kind of interesting. And your study makes me think that maybe we have to rethink what that means. I mean, I guess we see this in mice that you induce massive secretion of mucins into the airway. We think that's bad, that's mucus plugging, but maybe not. Maybe because they're in the background of ETI is the difference.
Mm-hmm. Mm-hmm. That's a really good point. Thank you.
I have one question. Maybe it's jumping ahead a bit, but if we are looking at a larger, phase 2 type study, what functional outcome measure would you want to pick? I mean, spirometry or MBW didn't seem to be giving it. Maybe you need to talk to Scott about
No, we've been talking actually, but that's one thing that has come into consideration. Imaging, I think, is going to be is very tempting to do imaging. We know with low dose CTs nowadays, we could get mucus scores, and that's been used a lot in the asthma and COPD literature. And if we're talking about mobilizing, particularly from the periphery mucus plugs, that could be a way in which in a phase 2 small study we could get that visual of how much of that we're affecting. But I think also, remember, this is just single dose. I'm still interested in seeing with repeated dosing what we can get with an LCI.
Sure. Any other questions from the floor? If not, thank you so much.
Thank you.
Great way to wrap the workshop. So thank you to everyone for coming. Thanks for the great questions and discussions, and enjoy the rest of the conference.